I'm going to talk a bit about the mechanics of breathing. And so this can be a little bit tricky. It's how does air actually move into our lungs? And it all has to do with pressure gradients. I try to make sure that you don't have to memorize all of the individual pressure numbers. I don't think it's as important as understanding the concept of how air enters our lungs and our small airways. So in order to understand how air can actually enter our lungs, there are some basic principles that you have to keep in mind. That number one, air travels from an area of high pressure to one of low pressure. That's a very basic fluid dynamics kind of principle. And number two, you need to remember that as volume increases, pressure decreases. And so that will help us determine what our gradient is. So in order for inspiration to happen, we have to keep in mind a whole bunch of things. Number one, oh, that was fancy. I usually don't get fancy with animations. Okay, so we need to keep in mind atmospheric pressure. So what is the pressure of the air that's outside of our body? We have to keep in mind something called intrapulmonary pressure. So pulmonary just refers to a lung. And so inside of the lung, we need to talk about what the pressure is. And if we know what the pressure is, we can deduce what has happened to the volume because they're inversely proportional to each other. We need to talk about the intrathoracic pressure. So the pressure that's inside of the entire thoracic wall. And quite honestly, that's going to change exactly the same as the intrapulmonary pressure does. And then there's this kind of difficult concept to grasp called intrapleural pressure. And that is the pressure that is inside of the lining of the lungs. So remember, there's two layers to the lining. It's the pressure that exists in between those two layers of pleura. And that is going to be a very important thing to keep in mind. And the reason for this is that there is something that is referred to as negative pleural pressure. And there are opposing forces in the lungs. So the lungs actually consist of quite a bit of elastic tissue that want to actually collapse the lungs down. And so there's a force actually pulling on the lungs to try to collapse them. And at the same time, the thoracic wall says, nope, we're staying right here. And there's an equal force that is pulling the lungs to stay open. And whenever you pull on a closed circuit or a closed system, you pull in opposite directions, or there's a force in opposite directions, it's a physical law that it actually reduces the pressure within that circuit. A good example of this is if you've ever at the grocery store taken one of those plastic bags and tried to open it, and it seems like the two sides of those like plastic produce bags, it just kind of sticks together because you're trying to pull them apart. And that's because when you're trying to pull on those the two sides of the plastic bag, you're producing a negative pressure within there that acts kind of like a vacuum and sucks them together. And so what this really does is it produces this negative pressure that helps make sure that the pleura sticks to the thoracic wall. And because there's this little negative pressure that almost helps the two layers of pleura kind of stick together, and it helps the lungs stick to the wall. Now, here's a question. There's two layers of pleura. Why aren't they just pulled apart? Why doesn't the visceral pleura just completely detach from the parietal pleura? And why doesn't the lung just sort of collapse down? The reason for that is that the pleural fluid, it contains water, and there is a hydrostatic force between the two layers of pleura This water creates, because of the adhesive and cohesive properties of water, water creates a force that helps those two layers of pleura stick to each other. And it ensures that the lungs move with the thoracic wall and they don't move separately because of this pleural fluid and the water. There's a lot of hydrogen bonding that's going on with that, and the two layers of pleura end up just sticking together. So before inspiration happens, there's no air moving. So I want you to think about no air moving. And if there's no air movement, that means that there's no pressure gradient. That means that the pressure within the lung is exactly the same as the pressure in the external environment. So this doesn't really help us. We need to somehow create a pressure gradient so that air can rush into our lungs. And so you need to keep in mind those pressures. And I want you to also keep in mind that the force of the elastic tissue wanting to collapse the lung inward is exactly the same as the force of the thoracic wall wanting to pull the lungs outwards. So everything is staying stationary, everything is equal. Oh yeah, there's that negative pleural pressure that's helping make sure that everything's sticking to each other. Okay, so those are the three things that are happening. So far, nothing helps us move air into the lungs. Everything's equal, there's no gradient whatsoever. Well, when inspiration happens, we have muscles. So our diaphragm can move, contract, and it moves inferiorly. There's also the intercostal muscles. And the one on the outer surface, they're referred to as the external intercostals. And that particular muscle, it originates from the rib that is above, and it inserts onto the rib that is below. So when the muscle contracts, it will actually pull the rib upward and out, which is actually kind of interesting because this is now a new force that's created on this thoracic wall. We had that equal force that was pulling inward and pushing outward. But now we've created a new force. So there's an extra force pulling the thoracic wall out. And so that is very interesting because that thoracic wall now, it overcomes the elastic recoil of the lungs, and it will allow for the movement of the thoracic wall outward. And when the thoracic wall expands outward, it has now effectively increased the volume. The total volume of our intrathoracic cavity has now increased. Well, when we're pulling even greater on that thoracic wall, that pull that we're having, the harder you pull on that closed circuit of the pleura, the greater that negative pressure becomes, and the more that pleura sticks to the thoracic wall. So as the thoracic wall expands, it's going to pull the lungs with it. And so if we pull the lungs with it in all directions, the volume of the lung is going to increase because it's going to be stuck to the thoracic wall, it's going to be stuck everywhere, and it's going to expand. Well, now we can think about if the volume of the lungs has increased, we know through Boyle's law that the pressure has decreased. So now we have a pressure gradient between the atmosphere and the lungs, and air will rush into the lungs because air is going to go from a high pressure to a low pressure, and air will rush in. And so that's the process of how the mechanics of breathing works from an inspiration standpoint. I'm not going to talk about exhalation because it's largely a passive process. You may need to go through these slides a few times. I'm more interested that you understand the concepts of the mechanics of breathing rather than memorizing all the numbers of the negative pleural pressure and exactly how it relates to atmospheric pressure and how many millimeters of mercury it goes down. I want you to understand the concepts. I want you to understand the differences between the pressure from a conceptual standpoint. So you may need to go through the last 10 minutes and listen to this again. You may want to read this section in your textbook to really have a clear understanding of exactly how inspiration happens from a mechanics standpoint. But I think that if you go through it a few times and really pay close attention to each specific aspect, you'll understand it. So what happens with a collapsed lung? So maybe some of you are thinking, oh, then how does a collapsed lung happen? And so a collapsed lung is called a pneumothorax, and it literally means air in the thorax, which air in the thorax is fine when it's in the small airways, but air is not okay in the thorax when it goes in between the space of the lungs and the thoracic wall. That's very bad. And so air, if it gets into that intrapleural space, well, the atmospheric air is now going to push on the lungs, and there's going to be a force trying to push the lung outward or try to make the lung recoil even more because that air has atmospheric pressure. As you try to exhale, the pressure within the lung, because it's collapsed, is going to force more air out. So every single time you try to open your airway to bring air in, this lung gets smaller and smaller and smaller and smaller, and the pressure gets higher and higher. And you can imagine that this is quite a serious issue. The question is, how does air actually get into this space? There's a few ways that air can get into this space. Either one, you can have a problem with some of the small airways within the lung actually rupturing, and air can leak out into the intrapleural space, or it's logically enough, it's if you have a puncture wound through the chest, say that somebody was stabbed in the chest, and there's now a hole between the thoracic wall and the lungs. Well, air can rush in through that hole, and air can get in. So those are two ways that air can get in. So air won't be able to rush into that lung. And you might say, well, it's fine because air can get into the other side. And that's true. That is true. But there's a problem because the lung contains more than just the airways. The lung also contains really massive blood vessels where the right side of the heart is trying to pump blood into that side. And the right side of the heart is not supposed to be pumping at high pressure or against a high pressure circuit. So if somebody has a collapsed lung, all of their large blood vessels are compressed and are at really high pressure. And so then the right side of the heart has to pump that much harder to try to pump blood to the lungs. And because the right heart isn't used to that and isn't equipped for that, the right side of the heart fails fairly quickly, and then very soon after that, you can get total heart failure. So these, in the case of a pneumothorax, it depends on the type of pneumothorax, to be honest, but they need to be treated very quickly, and they're treated with one of two methods. And usually it's both. They'll put a tube in, so they'll actually put a tube into this space that will suck the air out. And then the second thing that is usually happened is whatever is damaged will be repaired. So if there's a hole, that will be repaired. If there's a hole in the lungs, that area of lung with the hole will be removed so that air can't leak out anymore. But this is really just what happens when there is when there's air in the intrapleural space. It's a bad thing. It can be a dangerous thing, and it's called a pneumothorax. So the last thing that we're going to talk about is ventilation. And so ventilation is affected by a couple of things. It's affected by what is referred to as the compliance of the lungs, or how easily can the lungs inflate. And it's also affected by the elastance of the lungs. So the tendency of the lungs to resist being inflated. And the lung, as we've sort of seen in our mechanics of breathing, where they want to recoil back, we know that the lung has natural elastic fibers that cause the lung to want to resist being deformed. And what we really require in our lungs is a balance of each of these. The lungs must be able to inflate easily enough to allow for inspiration to occur, but they also must be able to return to its original state to allow for exhalation. So we really want a balance between the compliance of the lungs and the elastance of the lungs. And so I sort of think of it like a balloon. The more your lungs are inflated, the more they want to recoil back, kind of like a balloon. A balloon that's deflated won't want to deflate more. So the elastance is very low. But as you blow up that balloon, if you let go of that balloon, it's going to recoil back, and it's going to recoil back quicker, and it's going to recoil back with a higher intensity. So as you inflate your lungs, the elastance, or the elastic recoil, or the tendency of it to return to its original state increases. So there's a balance of compliance and elastance. And so in order to inflate our lungs, we really have to keep in mind something called surface tension, because all of our airways are moistened with water, and water has an extremely high surface tension. And the surface tension within an individual airway within our lungs, it can be massive. And no muscle in our body would ever be able to inflate that airway because the surface tension is massive. And so the surface tension is determined by something called Laplace's law, whereby the pressure within a sphere, and we're just going to say that our alveoli are spheres, is determined by 2 times the surface tension of whatever the fluid is in there, divided by the radius. So what that's telling us is that smaller spheres have a much higher pressure than larger spheres. The larger the radius, the lower the pressure. And so this actually creates a bit of a problem, because all of our alveoli in our lungs are not of the same size. So what that would mean is that our larger alveoli are going to have a lower pressure in it and are going to inflate much more readily than our smaller alveoli. In fact, our smaller alveoli would just never get air, because air would preferentially go to the lower pressure area. And so this surface tension creates a problem. It creates the problem of, how do we ensure that our lungs and all of our alveoli in our lungs are going to be inflating with the exact same amount of air? And so there is a substance within our body that, within our lungs, that is created that help us do that. And so this slide is just describing that all of our alveoli have a thin layer of water, and water has an extremely high surface tension. And that surface tension is because the cohesive property of water and the adhesive property of water. And what would happen is that just these tiny alveoli won't inflate. But our body has something for that. And that is where the surfactant comes in. And surfactant is something called a surface active agent. I guess they took letters from each of these words and just made a word that sounds clinical. That's what they did, surface active agent, surfactant. And what surfactant does is it disrupts the cohesive property of water and will effectively reduce the surface tension within the alveoli. And if it reduces the surface tension within the alveoli, you will reduce the pressure within the alveoli. And the surface tension ensures that all of the alveoli will have a similar pressure. And the way that it does that, it's actually a very, it's very clever the way that the body works out. If you think about a large alveolus, imagine this is a large alveolus, and each of these blue dots is surfactant. Well, a large alveolus, you can see that the surfactant molecules are less concentrated. Because they're less concentrated, this surfactant is going to have less of an effect on a large alveolus. It doesn't need to have a huge effect because it's already a lower pressure alveolus. Compared to a small alveolus, whereby all of those surfactant molecules are very in close proximity to each other, and there's relatively speaking, there's a higher concentration of surfactant at every single location within this alveolus because it's smaller and all those surfactant molecules are more concentrated. So a smaller alveolus will have, the surfactant will have a more of an effect on reducing the surface tension in a small alveolus compared to a large alveolus. And on average, the surfactant plus the size of the alveolus, it sort of equals out. It'll equal out so that the pressure across all of the alveoli are equal, so that all of your alveoli will inflate uniformly, so that this alveolus will inflate at the exact same rate as the smaller alveolus because of the higher activity of surfactant in this one. So we've now sort of learned how our body overcomes the issue of surface tension of water. It's with surfactant. But we also have to keep in mind that our airways are tubes, and there's a fluid flowing through those tubes. It's air. And just like our blood vessels, the radius of the airways determines the resistance to flow. And so remember Poiseuille's law, whereby our resistance to flow was inversely proportional to our radius and was directly proportional to the length, was directly proportional to the viscosity of the fluid. In our airways, the length of the airway, just like our blood vessels, and the viscosity of the fluid, just like when we talked about the blood vessels, length and viscosity are going to be essentially constant in our normal physiology. So therefore, again, the only factor that's important in determining resistance to airflow is going to be the radius of the vessels. So think about when you've had a cold, hard to breathe through your nose. And it's not because there might be mucus and stuff in there, but it's because of the inflammation within the airways is reducing the radius of the lumen within your upper airways. And the reduced radius is going to cause there to be an increased resistance to airflow. So it's very difficult to breathe in. If you have asthma, or you know someone with asthma, you know that they have difficulty breathing during an asthma attack. So in asthma, the very small airways, the bronchioles, will constrict, the muscle within it will constrict, and the very small airway radius is reduced. So it's hard to get the air into the lungs. And so people with asthma struggle to get air in because of that reduced radius and the increased resistance to airflow. And so a couple of terms that we need to talk about, just like when we talked about vasoconstriction and vasodilation with reference to the blood vessels, we can actually talk about synonymous terms in the bronchioles. When we talk about bronchoconstriction, which is the contraction of smooth muscle in the bronchioles, and it leads to a smaller radius in the bronchioles, and therefore there's a increased resistance to flow. And the major factor that will cause this is parasympathetic input. So if our parasympathetic nervous system is active, it will cause bronchoconstriction. Bronchodilation is exactly the opposite. It's relaxation of the smooth muscle within the bronchioles. It leads to an increased radius of the bronchioles and results in less resistance to airflow. And so air will travel more quickly. And so sympathetic nervous system activation will cause bronchodilation. And it makes sense because fight or flight, you want to be able to bring in as much oxygen as you can, so your airways are going to open. And it's specifically those beta receptors. Remember we talked about the beta receptors in the heart? A different type of beta receptor, a beta 2 receptor, will be activated in the bronchioles by epinephrine or norepinephrine, and it will cause there to be bronchodilation. Anyone who has asthma is often given a blue inhaler, and that blue inhaler is called Ventolin, and it contains a drug that acts to stimulate activity of the sympathetic nervous system and will activate these beta 2 receptors in the lung to allow for the relaxation of the smooth muscle, and will increase the radius of the bronchioles and will allow people to breathe. And this Ventolin is very fast acting, so people will often take it when they're having an asthma attack. Okay, so now that we know how we get around inflating our alveoli uniformly, and we know about changes within our airways and how the radius affects the airflow, we can now talk about total pulmonary ventilation, the total volume of air moved into and out of the lung per minute. This is like the cardiac output of the lungs. It's the total amount of volume of air that's moved in and out. If you ever hear the term minute ventilation, it's exactly the same thing. And so when we talk about total pulmonary ventilation, all we have to know is how many times per minute we're breathing, and we have to know what the tidal volume is. So what volume of air are we taking in per breath, and how many times are we breathing per minute, and that will give us our total pulmonary ventilation. So it's a fairly easy calculation. Our typical ventilation rate is somewhere around 12 breaths per minute when we're quietly ventilating. And our tidal volume we know is about 500 mils per breath. So we can calculate our total pulmonary ventilation by taking that 500 mils per breath times 12 breaths per minute. And our total pulmonary ventilation is somewhere around 6 liters per minute. Fairly simple calculation. And so the big question is, does this represent the amount of fresh air that reaches the alveoli for gas exchange? And if you've never thought of it before, you might immediately think, well, yeah, we're breathing in and we're breathing out. But that's not true. It is not the actual amount of fresh air that reaches the alveoli. This is the last concept we're going to go through. And so the reason why it's not the amount of air, and I'm going to show a graphic about this so that we can really understand where the air is going, is that some of the air that's moving through the system actually doesn't participate in gas exchange at all. So air that passes by the trachea and bronchi, those airways aren't doing anything for gas exchange. So when we breathe in, some of that air is still in the trachea and still in the bronchi. It's just sitting there until we exhale. So that area where air's going in but staying in the larger tubes until it's exhaled, that's referred to as anatomic dead space. And it averages about 150 mils per breath. That's how much is in the airways that don't conduct any gas exchange whatsoever. So here is the graphic. So imagine that this is your lung, and we are at the end of inspiration. So we breathed in 500 mils, and we have 150 of those mils are still in the trachea and the bronchial and the bronchi. When we exhale that 500 mils, okay, we exhale 500 mils, 150 mils of that is the part that comes out of the dead space. It didn't even participate in gas exchange at all. And only 350 mils of that 500 were actually in the lungs contributing to gas exchange. We're actually in the alveoli. So we've now exhaled 500 mils, but only 350 of those mils actually participated. Well, let's look at what happens now. After we finish exhaling, there's 150 mils that was in the lungs, but is stuck in the trachea and the bronchi. That's stale air that was in our lungs that we haven't exhaled. So the first part of our new inhalation is going to be that first 150 mils that's stale air. It's stale air that was from our initial inspiration. And so when we take in a new 500 mils of air, the first 150 mils is not fresh air, that's stale air. The next 350 mils of air is actually fresh air that's reaching the alveoli. And the last 150 mils that's actually coming from that 500 that we're taking in from the atmosphere is staying in our trachea. So at every single point in time, we're only moving 350 mils of air because 150 is never used in gas exchange and 150 is stale. So we're just constantly bringing in and out 350 mils into the alveoli. And so we have a way of determining what is the actual amount of fresh air that reaches the alveoli. And I'm going to show you here, and then we're going to do a couple calculations, and then we'll be done. So the alveolar ventilation is the amount of fresh air that actually reaches the alveoli. So total pulmonary ventilation is just talking about the amount of air that's moving in and out of the lungs. It doesn't matter where it's going, it's just moving in and out of the lungs. But when we specifically talk about alveolar ventilation, it's specifically the fresh air that reaches the alveoli per minute. And the alveolar ventilation takes into account that anatomic dead space. So let's do a calculation here. So we have alveolar ventilation, and the way that we calculate this is it's exactly the same ventilation rate or respiratory rate. I usually call it respirate, but ventilation rate. So how many times are we breathing per minute? And then we have to multiply that by how much air is actually reaching the alveoli. Well, that's equal to our tidal volume, the amount that we're taking in, minus whatever's in the dead space. And that's usually about 150 mils. So in most examples, it would be 500 mils minus 150 mils. So it would be that 350 mils that is reaching the alveoli per minute or per breath. And then we multiply it by how many breaths per minute. And that'll give us how much fresh air reaches the alveoli. So let's go back for a second here. And it says complete the table showing the effects of a breathing pattern on alveolar ventilation. And so it's looking at normal breaths, shallow breaths, and deep breaths. So this is actually an interesting concept to talk about, because sometimes if you think about it, is it better to do short, rapid breaths, shallow rapid breaths, or is it better to do deep, slow breaths? What will give us more fresh air to the alveoli? And so let's do these three examples. I'm going to share my screen and we're going to work through them together. So we'll work through the normal 500 mils per tidal volume. I know I haven't shared my screen yet. I'm just writing these down on my little whiteboard so that I don't have to go back and forth. So the volume of air we're going to look at the ventilation, the rest rate. I'm going to call that RR. So when you see my screen, you're going to see it as RR. Pulmonary ventilation, alveolar ventilation, and I'll just be sharing it in one sec, just air to alveoli. And the alveolar ventilation. It's going to seem a little messy at first, but we're going to, we'll work through it. I'm not a very good drawer. So our shallow breaths are 300 mils per breath, and our rest rate in that case is 20. And then we're going to do the example of a volume of air of 750, and we're going to take slow breaths, and we're going to calculate which of these is actually going to give us a better fresh air to the alveoli. Which one is actually going to give us better fresh air? Okay, now I'm going to share my screen. Okay, so here's our little chart. So in our first example, we're going to calculate our alveolar ventilation. And so for 500 mils, where our rest rate is 12 breaths per minute. Okay, and so the first thing that we really just need to know is that the air that's going into the alveoli is equal to the air into alveoli is equal to our 500 milliliter tidal volume, that's our VT, minus the dead space. The dead space we know is 150 mils. And so minus our dead space is 150 mils. So what we get is the air that's actually reaching our alveoli per minute is 350 mils. So if we get our alveolar ventilation, that will be equal to 12 breaths per minute times 350 mils per breath. If we work that out with our calculator, we will get 12 times 350 is 4,200 mils. And this is going to be the amount of air that's going to reach our alveoli per minute when we're quietly respiring. We're at rest. We're not really thinking about our breathing. This is what's going to be going to our alveoli. Okay, so we have a 4,200 mil. Our total pulmonary ventilation, well, that one is we take the exact tidal volume times our breaths per minute. So our pulmonary ventilation is just equal to 500 times 12, which is 6,000 mils. 6,000 mils. Okay, let's do the example of 300 mils with 20 breaths per minute. Okay, so now we're having rapid, shallow breaths. And so we have 300 mils per breath. We have 20 breaths per minute. And the amount of air that's going to stay in our trachea and our bronchi doesn't change. It's 150 mils of dead space. So our total pulmonary ventilation in this case, total pulmonary ventilation, is just equal to the tidal volume times our rest rate. So in this case, our tidal volume is 300 mils, and our rest rate is 20 mils per breath. And that gives us a total pulmonary ventilation of 6,000 mils. So it's the same as what we had up here. But let's look at our alveolar ventilation. Alveolar ventilation is equal to our respirate times our tidal volume minus our dead space volume. So what we get is 20 breaths per minute times 300 minus our 150 mils. And if we work that out, it should be about 3,000, I think. Yeah, that makes sense. Yeah, so if we work that out, we get 20 times 300 minus 150 is 150. And that gives us 3,000 mils. So short, shallow, or quick, shallow breaths gives us, we still have our 150 mils of, that should say 350 mils to our alveoli. Air to alveoli is 150 mils in this case because 300 minus our dead space of 150 is 150. So our total pulmonary ventilation is 3,000 mils. We're getting less than if we were just at quiet respiration. So then let's look at the last example of our slow, shallow breath, or slow, deep breath, breaths, where our volume we're taking in per breath is 750 mils. Our respirate is 8 breaths per minute, and our respirate is 8 breaths per minute. Oh yeah, and our dead space is always the same. Dead space is 150 mils. That doesn't change. So let's look at our total pulmonary ventilation. Total pulmonary ventilation is our respirate of 8 times our tidal volume. So 8 times 750. If we multiply that out, we should get, I'm doing it right now, is 6,000. So 6,000 mils, no different in terms of our pulmonary ventilation. But let's look at our total alveolar ventilation. Well, this is equal to our respirate times our tidal volume minus our dead space, always the same. And in this case, we get our respirate is 8 times our tidal volume is 750 minus 150 for dead space. And we end up with 8 times 600 mils, which is equal to 4,800 mils. So slow, deep breaths gives us more air in our alveoli per minute than fast, shallow breaths. So the slow, deep breaths really does help improve our air exchange that we have and our oxygenation levels based on these formulae. Okay, so we're going to end there today, and next day we'll be talking about. Next day we're going to talk a little bit about gas exchange. We're going to talk about the ventilation and perfusion. So the ventilation plus the blood flow and how they have to be matched. If you don't have one or the other, you run into a problem. You actually have both in order to have gas exchange happen. And then we'll talk a little bit about the movement of oxygen throughout the body and hemoglobin as well. So we'll end there today. A lot of concepts today, so you may have to go through certain sections of this presentation for a second time. And as always, if you have questions, please let me know, and I will answer them as soon as I can. Have a great day, everyone. I'll see you next time.